Hi, good afternoon, everyone, and welcome to our webinar, The Patient Identity Imperative. We'll get started in just a minute, but first I'd like to get some housekeeping items out of the way. If you have any questions during the presentation, you'll see a chat box where you can submit them. I'll field the questions and our speakers will answer them at the end of the presentation. Also, if you missed something or want to share the webinar with colleagues, we will be recording it and will make it available online later today. We'll also send you the link to the recording. Now I'd like to introduce our speakers, Joaquim Neto and Lorraine Fernandes. Joaquim is a senior solutions architect here at Hoover Otto with decades of architecture experience in information management with a particular expertise in healthcare with master patient index and health information exchange technologies. Before joining Hoover Otto, Joaquim worked at Initiate Systems for many years. Lorraine Fernandes is the principal and founder of Fernandes Healthcare Insights, a consultancy focused on information governance to build trusted data for insight. Lorraine was previously Global Healthcare Ambassador for Information Integration and Governance at IBM, where she worked to establish trust in patient, provider, consumer, and member data. She also served a variety of roles at Initiate Systems, including VP of Healthcare. She is the Regional Director for the Americas on the board of the International Federation of Health Information Management Associations. She is also a recipient of the American Health Information Management Association's 2013 Pioneer Award and the 2002 California Health Information Association Distinguished Member. I'd now like to pass it over to Joaquim. Go ahead.
All right, thanks, Nick. Thanks everyone for joining today. Before I hand things over to Lorraine to facilitate the bulk of this discussion on the patient identity imperative, I just want to give you a little bit of context of who we are, who Hoover Otto is, for those of you that are new to Hoover Otto, and explain the context for this webinar and why we asked Lorraine to come in and speak to you about the patient identity imperative. So Hoover Otto is in the patient identity space. The focus of our company is on resolving patient records, creating a longitudinal view of a patient. We have some very new and innovative approaches to that, things that are entirely new ways to approach the problem, built on big data technologies and available as a cloud or API service. I'm not going to get into a lot of detail on exactly what it is that we do, but we work with clients to take data from multiple EMRs, population health systems, payer systems, master patient index systems, and we rationalize that and link records together so you have the ability to access the view of the patient within an organization or across organizations. And we do that, like I said, through this cloud service. And I'll talk a little bit more about that towards the end of the presentation when I share some data observations that we've been able to find using our platform. So the reason we asked Lorraine to come in today is because we work with lots of different kinds of clients in the healthcare space, and inevitably they're the ones who are interested in managing the shift towards value-based care. They're interested in increasing the ability to interoperate with other organizations with the patient as a central focus. They're interested in analytics and improving the quality of data that feeds analytics. And we often get into conversations with them about what the trends in the industry are, what's happening at a federal level with regard to patient identity, what the various associations are doing, other collaborations. There's lots of people collaborating in this patient identity space. And we find that our clients are often trying to catch up and see what's happening out there. We also often work with our clients to generate business cases for them to invest in patient identity resolution within their organization. And these are all things that we've got experience with, but we wanted to bring in a real expert to talk about that. And that's why we called Lorraine and asked her to come in and talk to you today. So we're very pleased and thankful that Lorraine's joining us today. She's going to walk through a few different topics. So, starting with just the sort of the basics. Why is it so important today to create a foundation of accurate patient identity? Why is it more important today than it ever has been, really? She's going to talk about both this federal and private collaboration activity that's going on out there. And as part of that, she's going to reference some interesting work that's been done by others in the industry recently. And then we'll close out, and I'll provide some data observations that we've been able to make as Hoover Otto using our platform that support a lot of the points that Lorraine's going to be talking about that others in the industry have generated over the last year or two. So as I hand it over to Lorraine, we've got a poll here. It's the first time I've done a poll, so hopefully this will work. So it's a very brief poll that we're going to try to pop up on your screen here. If you can go ahead and make a selection and submit your poll in the next minute or so, we'll try to aggregate those results and have those ready for you a little bit later in the webinar. So as people are doing that, Lorraine, I'll hand it over to you, and you can take it from there.
Well, thank you very much, Joaquin, and thank you everyone for joining us today. I'm delighted to partner with Hoover Otto today to discuss the patient identity imperative. And as this poll closes down now, what I'll orient you to is the industry imperatives that we see underway today and how those are in fact marching activities forward. So there's many transformational activities. If you can move the slide for me, Joaquin, that'd be great. Many industry imperative activities around that are strategic and operational, that are really impacting what you do today and specifically impacting the priorities. You see what's shared here on this slide. These activities are striving to achieve that triple aim in a variety of different ways: to improve quality, which obviously all of us are healthcare consumers, and we hope that happens, to reduce costs, and then to improve access and consumer engagement, which is a bit newer than perhaps the discussion about bending the cost curve and improving quality. But it's interesting that in some aspect, every one of these activities needs a stronger, more accurate patient identification strategy. And I do say strategy because it is going to be a combination, I believe, of people, process, and technology that are going to make up the solution. They're all striving in one way or another, either as core or peripheral, to figure out, if I use myself, who is Lorraine Fernandes, where do I have data, and how do I aggregate that data for analytics, for research, for value-based payments in order to serve that data up, perhaps to the patient themselves or to the initiatives that are underway. What you see here on this slide, I think, are some interesting statistics about the transformative activities. And the statistics I find particularly informative, and you'll see we've sourced those for you in the lower right-hand corner. Even the CIOs, the CEOs, the CTOs, the CMIOs, they're very interested in making their strategic as well as operational decisions to drive those priorities and to drive metrics that validate that they are applying or pulling the right levers in order to achieve that triple aim. So innovation, service to consumer, and that triple aim are really what it's all about today in addressing the healthcare paradigm as that addresses other facets of healthcare. So as the next slide shows you here, we broke down groups into 4 different boxes of who's doing what for a brief review of what's happening in the industry, because there's been a lot of activity over the past decade, but not much change in what's happening with the solutions that are applied to patient identity, the business processes that should be changed perhaps as a part of your initiatives. And so I'll start in the upper left-hand corner, specifically talking about the government. We're going to talk about ONC and HHS and CMS a little bit later, but I thought it was interesting as we prepared for the webcast to think about what the PCORI Institute, the Patient-Centered Outcomes Research Institute, is doing, because I actually have had the pleasure of working with HealthX, one of the HIEs in New York State, that's a part of the New York City Clinical Delivery Research Network that makes up their PCORI award. And they're building from that solid foundation of who is their patient, where does the patient have data, bringing a lot more consumer data into their award execution, and then de-identifying data. So interesting happenings in the public sector, both on the practical aspect as well as research and policy. If you move to the upper right-hand quadrant there, you see the associations, and we're going to talk specifically about Sequoia a little bit later on, but a lot of activity from the associations trying to advance the conversation around standards, trying to build collaboratives across the many stakeholders that are represented there. And in fact, as almost all of you probably know, the CHIME Challenge is underway, and it's a bit interesting because they appear to have changed the rules of the game along the pathway here. So I have people ask me, well, what do you think is going to be the outcome of the CHIME Challenge? And I have to frankly say, at this point, I have no idea because it's hard to figure out common denominators across the finalists because they're not well known nor publicized on the internet, and since the rules appear to have changed over the last 6 months. So the jury's out as to what might really come at the end of the year from that. AHIMA, and we're going to talk a couple of times in this webcast about AHIMA activities. They've published a fair bit around patient identity, and I've been involved in many of those work groups over the past decade. We've done a lot to build practice briefs, to establish best practices, to try to get the AHIMA membership fully behind applying better policy, better process, better technology, because in many, many organizations, the data stewards, in fact, come from the Health Information Management Department. And again, we'll talk about AHIMA a little bit more and some of their stats throughout this. So let's go to the lower left-hand corner there, where it's the EHR vendors, the population health vendors, and the health information exchange vendors. As I was researching what I would share in this webcast, it was interesting to me that I understood that each of these certainly realized that how to match patient data across systems is important. But when I went specifically to the Health Catalyst website, they've got a whole case study devoted to one of their warehouse clients, and in fact, how fundamental and foundational patient matching is to their population health and their various other initiatives that are underway with that client. So I thought that was really affirmation from that particular market segment, along with all the others you see here doing activities, about how important patient matching is as we march strategic and operational initiatives. So the last one I'll touch on is the identity specialist, including Hoover Otto, and I thank them for sponsoring this. But I think their goal is to really look at this in an innovative fashion, and Joaquin's going to talk about that innovation at the end of this webcast, because doing the same old that's been in place for several years isn't going to change the practices and the quality of the data at the rate that we're going to explore in just a moment. So as the next slide shows you here, and I also found some very interesting industry quotes out there that really validate how broadly this patient identity imperative is being discussed. Many of you have probably seen the CHIME survey from a few years ago where they talked about 20% of the adverse events really tracked to patient identification problems. Granted, that 20% includes issues with wristband and bedside identification, but a large portion of that is probably the errors that happen at the patient access or patient registration. Mickey Tripathi, in an address he did a couple of months ago, talked about FHIR and the fact that people are seeing this as the universal magic silver bullet, well, he said it's not going to be that, and I would hazard to say that as our conversations go forward here, I'll share that a national healthcare identifier will also not be that silver bullet. So Joaquim, if you want to advance it, one more there, we'll talk about the federal perspective and what's happening in the federal space there. What this timeline shares for you is just for the last 3 years, what's been going on at HHS and ONC, and in fact, I added a CMS citation in here because a great deal of conversation led by the federal government or the federal government departments in collaboration with private initiatives is really trying to get a handle of what's the data we need, what are the attributes we need, what are the quality of that data that we need in order to do effective patient matching across a very diverse ecosystem out there. Last week, in fact, what happened with the House Appropriations Committee is there is, in fact, specific language in it now that directs HHS and ONC to provide technical assistance to private sector initiatives to develop a coordinated national strategy. Now, we all know that just because something gets in an appropriations bill doesn't mean it makes it out of the Appropriations Committee, or even if it gets to committee and gets passed, then it has to be funded, and that's the classic where the rubber is going to hit the road. So spending a little bit more time, we'll talk a couple of minutes about the Shared Nationwide Interoperability Roadmap, which came out late last year. You'll see here the roadmap, and it is an interoperability roadmap, but puts significant emphasis into the goals that are established in 2 or 3 year increments, and then the components that make up this interoperability roadmap in order to drive metrics. You'll see accurate individual data matching is a key component of this interoperability roadmap. And as the next slide shows you, they put metrics in place that they are recommending, suggesting, that be established by the various organizations in order to truly advance the level of data accuracy and data capture that needs to take place. So you'll see here in the L1.1, in the left-hand box, it talks about a 2% error rate of internal duplicate record rate being no more than 2% at the end of 2017, 0.5% at the end of 2020, and you'll see a 0.01 at the end of 2024. Interesting, aggressive, very quantifiable metrics that organizations need to be taking action today in order to meet those. And you might say to yourself, well, wait a minute, this is ONC suggesting this in their interoperability roadmap, so does it really have teeth, and do I need to march to that? And I would say to you, I believe you do need to march to this, because I think back to what happened with the ACOs several years ago when the federal government said, let's start accountable care organizations. They had about 35 pioneer ACOs. Well, today we have over 500 ACOs, with very few being sponsored by the federal government. The vast, vast majority of those are in fact sponsored by the commercial payers, the Aetnas, the Cignas, Humanas, and all the Blues plans out there. So while you may say, does ONC and HHS have the wherewithal to hold organizations accountable to this, I think you take action now, even if you have doubts, because I think once these metrics were published in late last year, I think you're going to see public and private and commercial sponsors picking up these metrics and realizing that if I had my subscribers meeting these, I would have cleaner, better data to meet my strategic initiatives, to manage claims data with the other types of data that payers may have, to do better research, etc. So in closing out this federal section here, the last stats I wanted to share with you are around, what's really in practice today in the communities, if you'll advance that slide, Joaquin. So what you see here is the ONC target that I pulled from 2020. And it's pretty daunting, especially when you think about what industry practices are. I went to a webcast about a month ago, and the poll that was done during that, only 34% of the webcast participants, and this was organizations from a health information, a HEMA perspective, 34% haven't started a governance program. 44% of those participants didn't know what their duplicate rate was. And this was, while it's not a statistical sample, it certainly should have represented people who were very vested in this problem. And 58% don't know how to calculate the error rate for duplicates within their organization. So very sobering stats considering what ONC is suggesting you have in place by the end of 2020. So moving on to the private collaborative perspective, we're going to talk for a minute or two about Project Sequoia and some of the good work they did and a webcast they did late last year and the framework that they produced focused on cross-organizational patient identity management. So they talk about the blind spot of cross-organizational patient matching and the various challenges in each of the 4 categories that you see listed there. Those challenges I would share, I believe, apply as much to internal organizations as to cross-organizational. When you look at this graphic here that talks about the goals on the pathway here as the arrow moves to the right, with the goal of reaching that 95%, which they believe is the performance limitation of doing demographic matching. And I believe that is assuming a lot of pre-work, manual labor, which can be expensive labor in marching those goals forward. And many organizations are taking those types of steps today and still have the suboptimal data and the lack of governance that we saw in earlier slides. So the other graph that I thought was interesting from Project Sequoia is when they talked about identifying the best patient match attributes. And like Joaquin, I've worked with EMPI, MDM data for a couple of decades now. So the data elements that you see shared there are the attribute names on the left-hand side. No surprise that those 14 make up what the Project Sequoia participants, which included, I believe, Intermountain and UHIN and University of Utah, and I think several other constituency groups in Utah. So these were the attributes that they studied when they talked about cross-organizational matching. And what they're trying to determine is how much trust and how much relevance and how much accuracy can you achieve with those data elements in order to match patients cross-organizationally. A couple of them that I would point out to you, I think it's interesting that they talked about the primary phone number and the fact that they had low data capture, obviously, in the distinctiveness of it. I think if this attribute were changed to phone number generically, and that included cell phone number, I think you would see a significantly higher trust in a cell phone number, given the portability and the market adoption of cell phones there. So it'll be interesting if they study this in years ahead, how they would approach cell phone, because Joaquim and I have seen it to be a very powerful matching element. The other I point out here is the Social Security number. No surprise, I'm sure, to many of you on this line, but the value and the capture for Social Security number has diminished dramatically over the last 10 years due to privacy concerns and people being unwilling to share their Social Security number. I'm sure we can all relate to that. Or people's practices of, if you ask me for my Social Security number, I'm just going to give you a bunch of 9s or a bunch of 5s, and therefore you have lack of validity in that. So interesting data elements that they have studied within their report that assess the attributes that can impact internal duplication and matching of records within an enterprise as well as cross-organizationally. So Project Sequoia, in kind of closing out their approach, they rated how you would assess and build trust on these levels of 0 to 4, and really we're assessing the maturity of how well organizations are doing with patient matching and with the quality of data in an internal or external cross-organizational approach, because it's all about building trust in their project across organizations. I would say to you that given my industry experience, I see probably almost all of the clients I've worked with, particularly over the last 10 years, probably at a level 1, with some of them at a level 2. I've really only seen level 3 when we leave the United States and we look at the Canadian provinces, or we look at Singapore or a few other countries like New Zealand around the world. And the reason the Canadians can go into that level 3 is because they started their whole initiative at a provincial level. So they put people, process, and technology in from the very beginning, and the net result of that was much higher data quality over, say, 12 to 18 months, so that they, in fact, can do cross-organizational patient matching and data sharing. And even nations that have a national identifier, I've worked with several of them, will generally layer on top some type of level 3 advanced technologies there, because they realize there are issues with trust and accuracy and fraud and the use of a national identifier. So that's why I'm a little bit skeptical about what's going to happen with a national identifier, and with saying that that could potentially be the silver bullet. I don't believe that. So let me close my section with a call to action and really talk about why action should be taken now, as opposed to waiting a year or 2 or 3 years to see what happens with some of the happenings in the industry. I think the first course of action I would share is to create a consistent, accurate, real-time holistic view of that person-level data, whether that's consumer data, member data, patient data. You probably have some activities underway today if you represent an organization, but I think you'll want to think more broadly than perhaps what you are today, because consumers are getting access to their data, so you need to be mindful to provide them the very best data that represents only their care, and that there's a very broad stakeholder group of parts of an organization that are creating data, or parts of an organization that are in fact using the data that's being created. So my second call to action would be to suggest that you develop a cost-effective, metric-driven, agile approach to meeting the ONC metrics. And I said earlier, you may not think that ONC has the teeth to do this, but I think you are going to see industry adoption of these metrics because ONC started the conversation and put a stake in the ground. And that interoperability roadmap that was released in 2015 really in many ways built on work that was done in 2014 and 2013. So it shows that progression of metrics, that progression of accountability, and the fact that we do need to have a solid strategy to march it forward. I would perhaps comically share with you that I don't think the way to do a cost-effective, metric-driven approach is to think, well, I'm going to swap out my current MDM or EMPI product for another, because you're probably just going to spend more money in 12 to 18 months in deploying that. So I don't think that's the silver bullet either to really achieving better quality, timely, cost-effective approach to creating and using your patient identity data. It's not going to be a one-size-fits-all, that's for sure. So it's time to go to work and not wait for the silver bullet. To use a people, process, and technology, not meaning to beat a dead horse there, but to really build that multifaceted approach in order to address your strategic and organizational initiatives, because data left the silos it was created in long ago, years ago, and we need to be mindful of executing strategy and executing activities that we can't waste any more time, because so much use is in fact being made of this data. So my closing thought before I turn it over to Joaquin is to suggest that you be innovative, because doing the same old thing isn't going to change the data quality, the interoperability of that data, or solve that people, process, and technology problem that exists today. I think organizations are going to have to be agile. There may be some trial and error. There may be agility, particularly with the broader stakeholder group. And when you convene and expand this multi-stakeholder group, I think you're going to see, given all the uses of data, that it's time to take action now, because we can't wait for the silver bullet. We need to be innovative and agile today. So Joaquin, I'm going to pass it over to you now, as you can review Verato's approach to some of the challenges and some of the industry initiatives that have taken place, and in fact share with us the poll data also when appropriate.
Excellent. Thanks, Lorraine. Thanks for that that survey of what's going on out there in the industry. I think it's real helpful for people just to have visibility into that. And if folks haven't seen those documents and studies you've referred to, I definitely recommend going and taking a look at those. We're going to drill down a little deeper on a couple of those, so I can provide Verato's perspective on some of the points that you raised, Lorraine. So maybe we'll start with this, the target internal duplicate rates that you mentioned, and contrast that with the AHIMA study. Did a survey who said that organizations have current average error rates of 8 to 12%. So if you just compare those two things, and if you look at that 0.5% target by 2020, you've got to make a 20x reduction in just a matter of a few years. So that seems like a pretty daunting task. And following up with the idea of being innovative, we think the only way to do that is like you said, Lorraine, to take a totally new approach, and we think we have that here at Verato. So just looking at this duplicate rates, let's go ahead and bring up that poll that we did for the folks on this call, and see how those results look. So I'll give it a second so folks can just take a look at that. I think you're going to see it's actually very consistent with AHIMA's survey. There was also a data point earlier in the presentation that Lorraine presented where 44% of people didn't know what their duplicate rate was. It's a little lower on the attendee list here for this webinar, which makes sense. Everyone who's here today is already kind of invested in looking at ways to improve patient identity. So it's good to see that people have a better handle on where they are. But it still shows that just the idea of figuring out where you are and establishing a baseline is something that lots of organizations still need to do. So getting back into some of the details that I mentioned I would go into here on starting with the Sequoia Group. Lorraine mentioned a couple stats that I want to talk about. To put that into context, I'll give you just a little bit more information on Hoover Otto's solution. This is sort of key to understanding how we came about the stats that I'm going to share with you in a minute here. So our patient identity matching solution is founded on top of a graph database that basically has a longitudinal person record, meaning demographic data, the types of data that you manage inside of an EMPI or inside of an EHR for identification purposes. We have a longitudinal record of that for all the adults in the U.S., and we use that as basically an answer key to solve the question of patient identity. So you think of the approach we're taking is we're bringing a large amount of high-quality data into the equation, and we're using that to get better answers than you can get by only operating against the presumably lower quality data that you happen to see inside of your EMRs. So it's something that organizations have been trying to do for a long time, is increase the quality of data inside of their own systems. That's a long, hard road to do that. And so what we're offering is a way to bring in high quality data, combine that with the data you have inside of your systems today, and therefore be able to get the right answer much more quickly and cost effectively. So the benefit to having this data set is that we can actually do lots of analytics, both on our own data and then how our clients' patient data syncs up with our data. So I wanted to share a little bit of that with you and put in the context of these reports that Lorraine mentioned. So on one concept of historical data was mentioned in both the ONC and Sequoia project studies, and like I said, these are both worth reading in detail if you're in the business of patient identity management. And ONC made the point that incorporating historical attributes, especially for things like name and address, will provide a big uplift in the ability to match data. So we wholeheartedly agree with that. Sequoia project had sort of a complementary statement, which is, hey, address is a great attribute to use for matching, but they didn't rate it very high because of the perceived low stability. I shouldn't say perceived low stability, real low stability. 15% of the population moves every year, and therefore if you rely too heavily on address without the benefit of knowing prior addresses, you're going to be missing part of the equation. So to first provide some findings from working with clients, we see that of the duplicates that we identify, the linkages that we establish across medical record systems, we see that on average about 10% of the real matches that we establish are made between records that have different addresses. So it kind of reinforces both the ONC and the Sequoia project points, which is interesting. The way that we're able to identify that is because inside of this graph database I mentioned, which we call Carbon, we have this longitudinal history. So we have up to 30 years of address history for people. And if you went to one hospital a year ago, you since moved in the interim and then registered at another hospital yesterday, we're still able to see you clearly as the same person because we had that historical address on file. And so that's one example of kind of changing the game a bit and being able to squeeze a lot better quality answers out of data by having this additional information. Another thing that Lorraine mentioned on the Sequoia project was the idea of the data validity, which attributes are most recommended to be used for patient matching. There's a whole idea of establishing a new standardized set of data elements that goes beyond what's in practice today. One of the other things that Sequoia project did is they looked at combinations of attributes and tried to determine how unique they are and sort of use that as a measurement for, can this combination of attributes be used as a matching rule on its own? And one of the observations in there that they had was that basically name and date of birth, first name and last name and date of birth, is 95.7% unique. And so therefore it's a good indicator that two records are the same person, but it's not good enough. if you're in the patient matching business and delivering care to patients, you need to have accuracy that's, no false positives, more than 1 in a million or 1 in 10 million. So 95% accurate is not good enough. So first, we reinforce that. So the data that we've seen, we actually think it's closer to 85% as far as the ability for a name and a date of birth to be sufficient to uniquely identify someone, which is in the ballpark of what Sequoia found. So the range is, the reality is somewhere in between those two probably. But the point that I want to make is that we actually are taking a different view on that idea of uniqueness. Since we have this database of everyone in the U.S., we actually know which 85% of the population have a unique name and date of birth. So whereas the traditional approaches that have been used for matching records would say, name and date of birth, it's only 85%, 85 to 95% unique, therefore we can't use that as a criteria. With our approach having an answer key in the background, we take a different approach and we say, you actually can use that combination. You can only use that combination for that specific 85 to 95% of the population where it is unique. And the fact that we have this database, we can tell which records it is unique and not unique. So without getting too wonky on how that works, the takeaway is that if you actually have a large amount of data and you do the right analytics on the data, then you can incorporate some new matching rules that, again, kind of change the game versus what the traditional techniques have been in this idea of patient matching. The last thing here, Lorraine mentioned AHIMA a couple times. We showed some additional stats on that. AHIMA did some real good work in reporting of studies around duplicate resolution, one of which was an in-depth study that looked at 400,000 duplicates that had been resolved through manual processes. And this kind of raised the question raises the issue, organizations that have those lower levels of duplicate rates, the ones that are investing large amounts of human effort and manual resources to get down below the 4% range to be in the top tier today, and trying to work towards those lower internal duplicate rates. They're investing tons of effort to be able to do that. So with our solution using this answer key approach, we've shown that we can automate the vast majority of that work that's being done manually today. So this is by using those techniques that I just mentioned around better understanding what combinations of attributes are unique, incorporating more data, historical data, into the evaluation process. All these things together make it so 75% of the work, manual work today, we can typically automate. And so again, this result of this is, hey, you can take some innovative approaches. If you take the same old approach to trying to meet these new targets that Lorraine mentioned, you've got a tough road ahead of you, cutting the number of duplicates in half every year. If you look at some new innovative strategies like we have, you can vastly reduce the amount of time and effort, and therefore dollars, it's going to take to get to these sort of new targets that we think the industry is increasingly trying to working towards. 2% in a couple of years, down below 1% eventually. So I think we're right up against the last minute here of the webinar, so we might not get to questions. If you did ask a question, we'll try to follow up with you directly on it. But to kind of summarize here, if you understand this idea of how additional data can help you increase the accuracy of your patient matching while reducing the effort. If you've got sparse data, Lorraine mentioned the SSN being used less and less commonly, and that's kind of contributing to the difficulty in matching, then the idea of bringing in additional data to help you resolve it should probably make a lot of sense. And in general, this idea of automating what has been today a pretty manual process, and in some cases cost prohibitive because it's so manual. These are all great reasons to talk to us, and we'd love to tell you more about exactly what we have and how things work. And then, of course, Lorraine, you should, please contact Lorraine if you need help with your data governance strategy, understanding the bigger picture, forming a new strategy to take advantage of some of the innovative technologies and approaches that are out there today. So I think that probably wraps us up. So thanks everyone for attending and participating in the poll as well, and have a great day today.